I'm going to send so say on behalf of CSMSJ, we welcome you all, those online, those house. Thank you for coming. Special welcome to our guest,
White House here.
Dr. Kilian.
You got a phone charger.
Team. Also, Dr. Hurley, here earlier last year, this year. Special welcome to our executive, Dr. Bali, senior representative, and welcome as well, founder CMSJ, former executive team, and currently our Chief Development Officer, Development and Finance Officer. Of course, Dr. Lorenzo Gordon, acting vice dean, and Miss Daniela Hyde, registrar. Welcome. Welcome all. This is our guest lecture. We at CMSJ have embarked on a series of monthly lectures and had two presenters. This is our second one. Yes. We're honored to have Dr. February of this year enlightened us on the topic autonomic nervous system dysfunction, root of insomnia, dieting, and this was indeed educational. And we're glad to have her here as well. Today we have a very special guest, Dr. Kilian, who, like Dr. Thurwell is living in Canada, who will be presenting on the topic cutting-edge assessment, neuromodulation technology that will optimize health outside medicinal cannabis. That is should be. So we eagerly await her presentation. At this time, I invite Dr. Bali, our executive dean, an official introduction and an overview of CMS. Your turn now.
So good afternoon to all here and all those online.
This is the boss. Good afternoon, Dr. Balin. Good afternoon, everybody.
Guest lecture and our lecture in a monthly lecture series. Just a quick, very brief overview of Caribbean School of Medical Sciences, CSMSJ. We're now in our 10th anniversary. The school was founded by Dr. Neville Graham, and the founding members with Dr. Gordon side here from the beginning, taking the school forward. We are in a university, and we are registered with the University Council of Jamaica, the Jamaica Tertiary Education Commission, JTEC, and so we're full degree granting bodies with our charter. We have been in the function as doctors. We've actually training doctors. We've had 2 courses of doctors who graduated, now working in the system in Jamaica and doing very well. Some have gone on to postgraduate studies. So we're young, we're small, and as the Jamaicans say, we're little but talent, and we're strong. We're going to be growing further and getting better and go down. As any new school, we go through a teaching process, which that's where we are now. But as good youngsters, we will continue to grow from solid citizens. So this is just a very brief overview. So in order to get our lecture now, I've decided to come and introduce our guest lecturer, guest speaker. Slide. No, we have forgotten.
The first welcome everyone. It is a pleasure to welcome Dr. Rochagné Kilian, a seasoned emergency and family physician with over 18 years of clinical experience in high pressure healthcare environments across Canada and South Africa. Dr. Kilian is widely recognized for her pioneering work in integrative medicine with a special focus on chronic pain management, sports injury rehabilitation, and holistic wellness strategies. As the founder program director of Care Wellness Private Membership Association in Ontario, she has developed forward-thinking wellness models that blend preventative medicine and bioenergetics and patient education. Our experience includes advanced therapeutic approaches such as MIA activation, matrix repatterning, and quantum bioenergetics, positioning her as the forefront of innovative patient-centered care. Dr. Kilian's impressive credentials include a Bachelor of Medicine and Surgery from the University of Free State, Emergency Medicine Certification from the College of Family Physicians of Canada, and ongoing doctoral studies in integrative medicine through Quantum University. She holds professional license in both Canada and South Africa and is a member of several respected medical associations, including the Ontario Medical Association, College of Physicians and Surgeons of Ontario, and the Emergency Medicine Society of South Africa. Dr. Kilian is a passionate educator, program developer, and advocate for multidisciplinary healthcare approaches. We are honored to have her with us today, and we look forward for her sharing her knowledge and insights. Please join me in welcoming Dr. Rochagné Kilian.
Get my slides ready first, and let's start here. Okay, so today I'm speaking to people in this room and people online, and I have no idea how many people are online, so whoever's there, welcome, and it's always, we like seeing faces, but I'll look at the faces in the room today. And I appreciate the introduction, so it allows me to not spend time introducing myself again. You know enough about me, so I think let's get to the topic today. So, there was mentioned that we're going to be talking about neuromodulation. I'm not going to be talking about cannabis. We've got some other experts in the room here that probably know more about it, but we are still going to be talking about neurobiomodulation, but from a physical and more from a myofascial aspect. So if you see the topic there, rebooting the body, bioactivation as a scalable, low-cost solution for chronic pain. And how many people are actually excited to talk about chronic pain? I don't know if there's many. You are, you're few and far between. You are good. I know from being in clinical medicine, there's not many excited about chronic pain. And there's a very specific reason to it. So today we're going to be talking about chronic pain, but not rehashing the problems that we have with chronic pain. I would like for us to start talking about solutions as well. Sir, please go on. So we'd like you to talk that chronic pain is complex, and we know that's true. Been in clinical medicine long enough, we know for a fact that chronic pain is complex. But I would like to say it's not necessarily complex, but it doesn't have to be complicated if we understand the underlying mechanisms of it. And one of those modalities that I've learned that has changed my practice is myoactivation. So that's the one we're going to be talking about today. But before we start there, I can't necessarily get the answer from the people online, but I always like to start here. Who here loves anatomy? There's one person that loves anatomy in a room full of people. Yes, that's one person. And I can tell you, I was not that medical student. I loved studying. Anatomy was not one of those things that I enjoyed. And I think it's the way that we're studying anatomy. It's not the subject that's the problem. It's the way that we are taught it. We are taught as medical students, we go into a area that smells terrible. You're traumatized by the smell of going into a place with formalin. And you're studying anatomy that's a living entity, a breathing entity. And you're studying it on cadavers where there's no movement. There's no feel to those muscles. That's where we get a misunderstanding of what anatomy is as well. The next question, and if there's anybody that knows this answer, please answer. Obviously, the ones online is not going to be able to do that. I'll just hold on to it. Do any of you know which type of pain is the leading cause of disability worldwide? Any guesses?
I show.
Very close. Chronic musculoskeletal pain. Yes, absolutely. And then which part of the body is the most responsible for that pain as well as disability? You're correct, the spine is actually low back pain. So we definitely know, everybody that's in clinical medicine long enough, we know that we've got a chronic problem, a global pain problem. So according to the WHO, the leading cause of disability or chronic pain and disability that affects more than 1.7 billion people is chronic musculoskeletal pain. Of that, the low back pain alone is the top cause of disability in over 160 countries. So despite the fact that we have this major problem in our medical industry, we have not come up with new solutions. We keep on doing the same things, trying to expect different results. So the problem for patients, we're not even talking about practitioners right at this moment, the problem for patients with chronic pain is that they become trapped in these long-term care cycles. Starts with medications, imaging, referrals, procedures, with minimal functional improvement. Pharmaceutical approaches, especially opioids, if we know the impact that opioids have had on this world, on a societal level and an economic level as well as a medical level, we know that opioids is not the answer to chronic pain. It's been proven well enough that it does not change anything long term. And the problem is that many interventions are reactive and not proactive. We wait for degeneration to actually show up on the scans before we act. And by that time, compensatory patterns have been there for a long time and it's so hard to unwind. And then let's speak of imaging. I don't know in Jamaica how easy it is to get CT scans and MRIs. The problem with these beautiful diagnostics, it doesn't always give us the answer. It doesn't show us anything. Somebody is unable to walk and they get an MRI scan, and the MRI scan says unspecified. Does not give us any answers of why they have pain. And the reason is because pain do not always show up as a visible damage on diagnosis.
So.
Dysfunction. And this is from the way the body moves, compensates and protects, and imaging is not able to capture that. So we're spending more, we're prescribing more, we're doing more, but we're not getting better results. So we need to get to a point where we're asking the questions, what are we doing going around and around in the same cycle? So it is time to rethink chronic pain. And the World Health Organization actually had a whole gathering in 2021, and I took the time to watch through some of those talks, but nobody really offered any solutions, unfortunately. So what would a better solution look like? First up, it must go beyond symptom suppression, so no masking discomfort. No more chasing pain around the body with temporary fixes. Instead, we need to get to the root cause. Root cause sometimes sounds easier than what it is to get to. So if we do not have a duplicatable, effective assessment system that gives us an idea of what the root cause is, that is where we're going to be stuck in a loop where we're not getting any results as well. Then second, it must lead to real lasting change. So not just incremental relief for the patient, not a better than before. We've placated ourselves that if the patient is slightly better after they came to see us, that they're improved. Slightly better than before should not be our measurement. It shouldn't be good enough for us. Then it has to work in the real world. And this is when you pull back a little bit from the patient side and into the system side. And this is where it's relevant in a new medical school that's starting to change the paradigm of the systems, as well as in a place like Jamaica, where you need approaches that's cost effective, that can be scalable, it can be duplicatable, but it also doesn't increase the patient or the clinician load, because we know the clinician load cannot take a single extra weight on it. All over the world, the system is overloaded. Then, fourth, it must be safe. I think there's been a lot of misconception in the last few years where something is, if it works, if there's efficacy, we don't need to be worried about safety. And we should never forget about any intervention that the safety is one of the most important aspects for the patient. Just because we can do something, it doesn't always mean we need to do something. Then fifth, it must minimize dependence on pharmaceuticals, especially now, as we've said, with the opioid crisis all over the world. So if we have a modality that can reduce medication load, it's not just good medicine. I believe it can be public health leadership for us to implement these modalities. And then it must be cost effective. I mentioned that as well. Before we get to my activation, my name is Dr. Gordon. I asked this following question earlier at sports school. And the first question is, have you heard of the term biotensegrity? Has anybody here heard of the term biotensegrity? Yes.
We have a little problem with the audience on Zoom.
Okay.
They are not seeing the slides. So we're going to rectify them. You know, that's why we have to improve a little bit. So we're just going to copy.
Okay.
Perfect. So I don't have any problem. Sorry.
Save it to
Anywhere? Okay, good. So they're going to put our slides up and running. Slide five. Slides version. We don't have to start from the beginning. Remember I said I love technology, never know if it's going to work. Okay, so while they're getting ready, The first question was, who has heard of the term biotin integrity before? And if you haven't, we're going to be talking about it. But the second one tonight, I asked this at the sports school as well, is, does anybody know what anatomy of trains refers to? Which is not necessarily a bad thing when you're doing a presentation if people don't know, so we're going to get to that. And the last one is, and I have met very few medical people, even out of a realistic point of view, that know something about the primal vascular system. So we're going to be talking about all of these good things. And the reason that we're going to be talking about these things is because before we get to myoactivation and what myoactivation is, I'd like to step back and explain, or try to explain, why certain things work. Because if you understand the why, it's very easy for you to learn what. So with the myoactivations, the reason some of these things work is the fact that we're starting to understand the true mechanisms of the human body, something that goes far way beyond the textbook anatomy that we've been taught. So the first one is the myofascial system. We've spoken a lot about the myofascial system today, and 15 minutes ago we were at a physiotherapist's clinic, and we said between all of us, our practitioners, the thing that connects all of our specialities is the myofascial system. So it's one of those systems that keeps on being underestimated. So it connects everything in the body, and eventually it connects a lot of practitioners as well. So these different modalities need to start working together. But the myofascial system is a living, intelligent grid of muscle and fascia, constantly responding to stress, load, trauma, posture, and even emotion. That's where it can get very interesting. It's not separate parts, it's one continuous system. Then, when we're speaking about the myofascial chains, there is a gentleman called Tom Myers that wrote a very good book where he explains these myofascial chains, and he calls it anatomy trains. That's the way that he taught people. And basically, it's the concept that there is an interconnected web that has a specific structure where something in your left toe is most likely connected to your right shoulder. So when you're releasing something in somebody's leg and they start breathing better, it's not just a happenstance. There's a specific reason, and you're releasing some of those myofascial chains. So all of these concepts are important to understand for you to understand why myoactivation actually works. Then the concept of biotin integrity, and the picture that's in the slide there actually explains it very well. When I was still taught in medical school, I finished in 2005. The beautiful nature anatomy books that we all love, very expensive books, so you took care of that book. The problem with most of those books is in our mind there's a concept created that what comes first is the bony structure. It's this little bridge of bricks that you build up. Then it's the muscles, then it's the nervous system, then it's the skin, and all of these things attached to the bone. Where if you switch it around, it's not a brick and mortar construction bridge, it's actually a suspension bridge. And when you understand that concept, that the myofascial system is the underlying foundation, and the rest of it is added, and the bony structure is just added for extra support, that's when you start understanding the certain strain patterns as well as restrictions in some areas, why it affects the rest of the body. And then lastly, the primal vascular system. So this is one that has definitely not made it into our medical textbooks as well, but this is a hidden vascular as well as energetic communication network closely aligned with acupuncture meridians. So this is that bridging concept between the very wise Chinese medicine guys that have known things for thousands of years that has been denied access at the table, unfortunately, because they couldn't always explain why their things work. The primal vascular system is one of those physical structures in the body that are now starting to explain why the acupuncture points and meridian points are effective. Because the primal vascular system is a physical system that is constructed of primordial fluid, which is easy water, which has kind of become a buzzword in the last few years, but it's filled with stem cells, mitochondria, as well as DNA fragments. So when you're working on the body and you're stimulating that primary vascular system, the systemic effect can be vast because you're not just working at a local level. And then we can get to what is myoactivation. So if you remember back, we said, if we're going to look at a modality that can offer solutions for chronic pain, it has to have certain things that it takes. It has to be repeatable, low cost, low risk, all of those things that we've already mentioned. What is myoactivation? For me, of all of the things that I've found, it clicks the most boxes. At its core, myoactivation is a structured clinical approach that is designed to identify and release dysfunctional muscle patterns that either contributes to pain, to restricted movement, and to postural imbalance. And we're going to look at a couple of case studies later because I think we'll learn a lot by looking at different case studies to understand how can it support the system in different ways. But it's basically grounded in the understanding that chronic pain is not often due to local pathology, but rather to compensatory muscle dysfunctions, muscles that are persistently contracted, inhibited, or overburdened by faulty load distribution. And that is why our modalities often fail, because of this one specific component. When you're seeing somebody for your shoulder, and that's the only area they focus on, they don't get resolution of your pain. They don't understand where it started, so they never get to the root cause of why it started and why it's not healing. Then the technique was developed by Dr. Greg Spire, a Canadian emergency and chronic pain physician, who recognized the need for a reproducible, efficient method of resolving complex musculoskeletal presentation. When I took the training, he actually mentioned that he used to work on the oil rig ships. So he was the only physician taking care of men that really use their muscles and injure themselves. So he had to come up with a system because he didn't have diagnostics around him, he didn't have much support, and he had to get quick results because there's only a limited amount of people on the ship that needs to work. He needed to get them back to functioning as well. But what makes myoactivation especially compelling is that it yields immediate changes in movement, balance, rate, and pain levels. You don't need to wait 2-3 weeks to get the results. You see it immediately, and the patient is able to visualize it immediately as well. So that's why you're able to manage chronic pain. So the 5-step process with myoactivation is basically set out in a 5-step process. First up, you're mapping the pain. And there's 2 legs with this. First, it starts with history. We know as medical students, we always get taught the value of taking a proper history. And it's drilled into our minds in the beginning to ad nauseum, where you're so done talking about things and asking your members these lists and lists and lists of things. And you don't realize the value of that because we haven't made the connections and a system approach to things. We were taught to all ask all of these questions, but we never connected with the answers we're getting. So mapping the pain starts with the history. And this is a timeline of lifetime trauma. So this includes everything from accidents, surgeries, scars, old injuries, even when they were 2 or 3 years old. The body remembers those injuries and it creates compensatory patterns. So if you do not ask these questions and get the information, you're going to be searching for so much longer than at least getting some clues of where you need to go. Then the second step of mapping the pain is a duplicatable way of testing the body to see where there's restrictions. And this is the part that we focused on at the sports college this afternoon, where we had a practical application of all of this. Then secondly, observing posture and gait. As physicians, we get to a point where we're so used to starting our clinical assessment from the moment we touch the patient. We forget to observe them when we're even walking into the room. Or where they're breathing, they're sitting in front of you, the way that they breathe, the way that they sit. Everything is little clues of where there is restrictions in their bodies. So starting to be more observant of their posture and gait can be so helpful in figuring out where these issues are. Then the next one is palpating for tension. So this is where it's not very different from the Western medical model. Expect you palpate, and then you can percuss as well. With this one, it's more palpating for tension. So in muscles that are either contracted or constricted, or there's myofascial tension, most of the time you will feel a palpable change in that muscle. It will be tight, or there will be bands or strands, or there will just be a tender point that they have never, has anybody asked them, why is that tender point there? They didn't hit that muscle. If you touch normal muscle, there shouldn't be any tenderness. But if you touch this patient just with a gentle touch, they want to jump off your table. And it's because it's a trigger point that is held onto that tension. Then you're releasing the target muscles. So the difference with myoactivation versus other dry point needling and even acupuncture is that we're using a cutting needle hypodermic or cutting tip hypodermic needle. So if anybody knows a little bit about acupuncture, it's a rounded tip needle that they use. So you're not cutting through dense tissue, you're actually going through it. It's a very critical approach in that way. So you're speaking more to remember the primal vascular system. Is there any technical things, you guys? We're good? Perfect. So you're speaking to the bioenergetic body, where with myoactivation, even though the results can be the primal vascular system, they can be bioenergetic, emotional, you're speaking to the physical structure. So with the cutting tip hypodermic needle, you're actually cutting through those layers of tension and cutting through the trigger points itself as well. Then the rheostasis function. This is one of the most important aspects of myoactivation, not just for the clinician, because you're not just searching for clues and kind of just walking around in the dark. You release something, you reassess the patient. If something hasn't changed, you've missed something. So you go back to the baseline of testing until you see a release. And 99% of the time, you immediately see a release. So you know you're on the right track. So it's not even only important for the practitioner, it's also important for the patient. Because there's something in people with chronic pain that they are so stuck in that aspect of their chronic pain. So for them to just even see a 10% difference in the way that they move can be a massive change in their mood and even their motivation to now start getting better. And they've never been given that hope that there's something that can change that aspect. So before I speak about the base tests, we're just going to quickly look at some case studies, and I'll try to make this quick. First one, we mentioned low back pain is a massive issue all over the world, 160 countries. So the first one is a 44-year-old male farmer with chronic low back pain for 5 years, unable to work. If you think of a farmer not able to work, it's not something trivial. He needs to be able to do manual labor. Let's continue. So he needs to be able to continue with manual labor. So this gentleman came, he has seen physiotherapists, he's done the stretching, the medications, all of that. When we assessed him, it wasn't his low back area that was the problem. His quadratus lumborum came up, his gluteus medius came up, and his psoas muscles came up. So when we released these dysfunctional muscles just in 2 sessions, his back pain completely resolved and he was able to go back to work. The second case study we're going to look at, and it's something that can be very problematic in anybody that treats chronic pain, is actually frozen shoulder, or what they call adhesive capsulitis, because it can affect your life in such a major way. Just women not able to comb their own hair, tie their own hair, you underestimate what it does if you cannot move your arm the way it should be. So 53-year-old female, 2 years of limited mobility, she tried physio, injections, home exercise, everything that they always try with a frozen shoulder. With this lady, we did the assessment, we followed the 5-step process, and what came back was the fact that it was her subscapularis, so the one under the axilla, it was her pectoralis minor, as well as her levator scapula. So it's got nothing to do with the shoulder. There was nothing wrong with the joint. Once we released, once again, this was just a 2 session. So we get patients where you need 4 or 5 sessions, but this was a 2-session one where we released those. After that first session, she was able to lift her arm further than she's been able to lift it in 2 years. The reason that there's such a quick effect is our joints are so forgiving. It's made to be forgiving. It's got that shock impact. It's got fluid in there that wants to recover. But once we release it to start moving in the way it should, it wants to heal and the inflammation goes down as well. The next one is actually very relevant, I think, just to the Jamaican, oh gosh, the frozen shoulders, is the acute knee pain, and this is related more to athletes. We're good on the slides? So acute knee pain, this was a 19-year-old male, competitive soccer player, acute right knee pain, no trauma, so he didn't hear the pop. We know it wasn't any ligaments or the joint itself. I don't think it's changing. There we go. Oh, they need to change. Okay, perfect. So acute knee pain. No pop. He's tried the usual rice, the race, the ice, the compression, elevation, all of these things didn't make a difference. He saw the physiotherapist, they tried everything. But we know there was no meniscal injury, there was no ligament strain. But imaging wasn't indicated at that point because we're not going to put him through imaging if we know there's nothing wrong with the joint. We did the assessments, and with this gentleman, his adductor magnus, his vastus lateralis, and gluteus maximus came up. When we started asking his history, the same gentleman has had problems with recurrent hamstring injuries as well. It's not the hamstring that was the problem, it's the muscle that came up, the adductor magnus and the vastus lateralis. And if you look at a lot of these muscles, you'll see a lot of times it's the lateral aspects of the body that gives us the most problem. Our body is so used to just doing a forward and backward motion. All of our lifestyle is created around you sitting and standing. That's all you do. You don't move in a spiral way anymore like we did before. We used to, all of us climb trees. We had to climb over things, under things. The way we played as children made it so that the rest of our body compensated so that you didn't have that much injuries. But our lifestyles have gotten us to a point that the whole lateral aspects of our bodies are so in a compensatory pattern, so it's easier for injuries to happen. This gentleman, there was one session where we needled the vastus lateralis first. He already saw some improvement, the adductor and the glute max, and he was pain-free. And he went back to training the next day. And you can physically see the change in his knee. A lot of times, when I was in the emergency department, somebody would come in with a very similar thing. It's a swollen knee. Once you release that vastus lateralis, the swelling is gone. It's not a swelling in the joint where they usually want to go tap on it and all of that, but it's the vastus lateralis that's so contracted at the bottom that it creates a outflow problem. So then it becomes swollen because there's no outflow, there's no lymph draining as well. So it's an immediate result. The next one is one that's easy to forget when we think of issues with myofascial disturbances. That's the gait imbalance. So we can go to the next one on the slide. So 78-year-old female, let me just get to the slide here. 78-year-old female, chronic gait imbalances, frequent falls. We've all seen this. No stroke, no neurological abnormalities. But the one thing that came out of the history is she can no longer get off the toilet without help. And this seems like an insignificant thing. But if we understand that the loss of independence in elderly people, where they can't even get off the toilet by themselves, it opens up a whole other can of worms. Because you need somebody with that person just to take them to the toilet, to get them out of and out. So that loss of dignity, even with that one space of privacy that they've lost and they haven't had a stroke, can be a massive change. So with this lady, the first thing we did, obviously the assessments, her glute max, her iliopsoas, her quadriceps, and her quadratus lumborum. So once again, a couple of the muscles on the side. After the first session, she walked out of my office and they went to the bathroom. Her daughter was waiting just at the door. And when she came out, I asked her, is anything different? And she looked at me and immediately she realized she got off the toilet by herself. She's so, and that's one thing, it's one lesson to learn as well. People are so used to being stuck in these problems, she didn't even realize that she didn't need the help, but her body knew. Even though consciously she didn't know that she still needed the help, her body knew she was able to get off up off of that toilet with one session. And it took about 3 sessions for us to get her pelvis balanced, no falls afterwards, and she's independent, which is massive. And we know what strain falls in the elderly can be on the medical industry, because it starts a whole other thing with hip fractures, and then it becomes bed sores, and we know it can be massive. But how do we find the problem? So the first thing is the base test. So we can go to the next one. Base test is biomechanics assessment, symmetry, and evaluation. And this is the assessment system that was created by Dr. Greg Slyer. So with the previous slide, you'll see there's a research paper, an independent research paper that is mentioned that I can provide afterwards that you can read through, that gives the basis of what this structured system is. And biomechanics assessment, symmetry, evaluation. There's 4 levels of training. We can go to the next page for the base test, please. But the base test, there's 4 levels of training, but the level 1 teaches you about these base tests and makes you understand where there are certain restrictions. But with the base test, you're asking the patient, after you've done the history, after you've observed their gait, their posture, you're going to make them do some exercises for you. Each of these exercises gives you an exact detail of where there are certain restrictions. First off, it tells you where the movement stops, because it's not always just pain that's the issue. It's a restricted movement as well. Then, also, it tells you which side compensates, as well as postural asymmetries emerge when the system is challenged. When they're standing in the normal position with their compensatory muscles, you don't always see the asymmetry. But once you ask them to bend backwards, the whole body shifts into that compensatory mechanism. This afternoon, we had somebody demonstrated that actually had some musculoskeletal issues, and the class was able to see even that person bending forward for whole back end, the one muscle was higher than the other. So it comes out very, very closely. But the first one, I think our space is a little bit small. We're not going to be able to demonstrate it. But breaking it down into the first one is balance. This is probably of all of them, this is the most important one to start off with as a practitioner. And this is where it connects everything to the feet. And I always joke, if somebody understands the myofascial chains, orthotics would be out of the job. Because we would be correcting people's symmetries and they wouldn't need orthotics just to function on a basis. But basically, you're asking the patient to put their feet shoulder width apart, they're breathing in and out without looking down at their feet, and you're asking them to see where they feel the weight underneath their feet. And believe it or not, most people would be able to tell you exactly where they feel the weight. It doesn't matter if it's a 10-year-old or if it's an 80-year-old. They will tell you most of my weight is on the left front inner foot. And you take it out. And on that assessment, there's a chart that tells you if it's a front inner foot, most likely the restriction is on the inner leg on the bottom. For example, there's a whole structure to it. But that's where you start. Then, without them moving, you ask them to look down. And most of the time, there's one foot that's turned out, or the one is forward versus the other. Where if we're aligned in symmetry, our feet should be pointing in the exact same direction, without it being turned, without an inversion, without eversion. So them just visualizing, there's something that nobody's picked up on, it makes them part of the process. That's one of the magic parts. People that are stuck in chronic pain, they're taken out of the conversation, they're not active participants in their healing as well. So then visualizing is start that process. Then you move to the first test, the EAR, which stands for Extension Arms Raised. With extension arms raised, you're basically testing the posterior myofascial chains. So the paraspinal muscles, a little bit of the glute can show up there. If you see pain, they will usually tell you there's pain in their back, and most of the time they will actually tell you if it's on the left side or it's on the right side. Or if they don't feel pain and they're so restricted, most people, it doesn't matter if they exercise, it doesn't matter what weight they are, they should be able to extend their back. It's a normal move for people. Then you go to the second one, extension arms down. If they've got a problem with putting their arms next to their side and bending backwards, that's where it's the anterior chain. So there's muscles in the abdominal area that's contracted. Then you move on to the F.A.D. So that is the flexion with the arms down, and that shows you all of the glute areas. So gluteus maximus, medius, minimus. Then there's the last two, and this is just the base case. Squat arms down, and you'll see it's very difficult with the images sometimes, but squat arm down shows you restrictions in the quadratus muscle, so the upper leg anterior and the lower leg posterior. That is where there's restrictions if they have trouble either doing the squat, or they're imbalanced, or there's pain in the knees when they're doing that squat. As soon as they put their arms up, you're actually tasting the hamstrings on the upper legs. Now it's the posterior of the upper legs and the anterior of the lower legs, which is so specific. And I think that has been the magic with the myoactivation. People have started understanding myofascial chains. They understand biointegrity, but they haven't been able to consistently map areas where it's so easy for people to do most of these movements, and you're able to tell them the reason you have a shoulder pain is your glute on the left side is so contracted, it's no wonder your right shoulder can't move. And they're able to visualize it. So after these tests, what you do as a practitioner, you ask them which of the tests either had the most pain or felt the most restricted. And most of the time you can see it, but you want them to tell you which one it is, because it starts connecting their body with what they're feeling as well, because they've been so disconnected from their own bodies. And most of the time they will tell you the one that you picked up. That is where you start. That's where you palpate for painful nodes, and that's where you do the dry point needling. And as soon as you've done the dry point needling in that area, you ask them again to do the balance test. And immediately they say, oh, instead of the front inner foot of my left side, I can feel the weight now on my right back leg or my right foot. And now you're releasing it to layers. It's like an onion. You've released the most restricted one that's showing up in the body, but now you're working it backwards. That's not necessarily the one that started all the problems. You're working it backwards towards the one that was the original assault in the body. And that's what makes it so satisfying for a practitioner, is you're unraveling it and you're seeing the results right away. So that is the waist test. And we're almost done. I see the food is arriving as well. So at the end of the day, we can go to the next slide as well, please. And this part I'm going to read, so I want to make sure I say everything. So we've walked through a new way of looking at pain tonight, and I'm sure it's not the same as the pain presentations you've seen before. We've challenged some assumptions, we've explored real patient stories, and we've introduced a structured, functional model that gets to the root of dysfunction, not just the symptom. But I want to leave you with something broader. As clinicians, and especially as students, stepping into the profession, you'll be taught protocols, systems, and frameworks, and those are valuable. Absolutely, we need something to start with. But if there's one thing I've learned, it's this: we have to stay open. Open to the ideas that weren't in our textbooks. Open to the possibility that if something isn't working, it's not the patient who's failing the treatment, it's the model that needs to evolve. And that takes humility. That's probably the hardest part in this industry, unfortunately. Humility to admit when the traditional approach does not deliver. Humility to listen to the patient's story, not just read their chart. And then courage to explore innovative approaches that may look unfamiliar, but they offer real hope, better outcomes, and a more sustainable healthcare system. Because the truth is, approaches like myoactivation don't just benefit the patient, they reduce the system burden, they shorten treatment timelines, and they bring purpose, clarity, and satisfaction back to the practitioner. So as you step forward into medicine, ask yourself, are we treating pain, or are we listening to what pain is telling us? And more importantly, can we be bold enough to learn again, even after everything we think we know? And then the last slide that I want you to finish you off tonight is one of my favorite quotes from a gentleman that lived a very, very long time ago. Paracelsus. I would say he's a brother from another mother, and if we lived in the same timeline, we would have been in practice together. But he says the art of healing comes from nature, not from the physician. Therefore, the physician must start from nature with an open mind. And nothing is closer to nature than our own bodies and the voice of listening to what it's telling us. So let's close with a few final reflections. Where does this leave us? You came into this session expecting to talk about pain. What I hope you leave with is a new lens, not just for understanding the body, but for practicing medicine. Because pain isn't the enemy, it's a signal and it can be a teacher. And if we're willing to listen carefully, it will show us exactly where healing is needed. We've seen today that functional pain doesn't always show up in scans, it doesn't always follow the textbook, but when we assess intelligently, treat systematically, and approach each patient as a whole, not a part, we can help restore not just movement but dignity, independence, and joy. As future doctors, therapists, and healers, you have a choice. You can memorize protocols, it will serve you well, or you can develop the kind of insight that transforms lives. So stay curious, stay humble, and stay hopeful. Thank you. Questions, my questions.
Yes, excellent presentation. And it tells me that there are many things that I do not
That's a good place to start.
Yes. But I was listening for the neck area as well, because a lot of patients come, especially in modern times, because of people not there to computer, writing, and so on. Big office jobs where the neck and the back are really areas that sometimes we have to focus on. And I usually you tell them to exercise and so on, or actually do some point pressure on the areas that the muscles contract. But here there is a new and a more understanding approach to it. So if you can tell us about it.
So with the myoactivation, the level 1 training, that's the one that they use for their research articles. So that's what you'll see they're focusing on. But it's actually a level 4 training. So you start with the level 1, that's kind of the bigger muscles, the knees, the low back pain. And then you move to the abdominal, the thoracic, so there's a little bit more risk if you're going to be poking needles into, for instance, thoracic area, obviously. And then you move to the neck. And it's not necessarily because it's more complex to understand, it's just that confidence as a practitioner, if you've needled enough people and you create the confidence for them to stick a needle into your neck, that's where it gets interesting. But absolutely, you're right. The neck is a massive issue. But what we have found, apart from just working with the neck, when you release their hip flexors, a lot of their issues goes away. Because it's not just them sitting forward. The reason that their neck is pulled forward is that whole chain in the back is shortened. So the body has to compensate. We always blame the phone. It's easy to blame the technology. But our bodies are compensating with mechanisms that are not serving us. So we're not doing this with our neck on purpose. This is the only way our neck has to go, because our hip flexors have been shortened by sitting. So that's where people are starting to see results. If they're standing at their desks, because once again, you're extending the body, and the neck has a natural way of moving back, and it starts compensating. But it's a big area. It takes a little bit of faith on the patient, and even if they come with neck issues, you start with the bigger areas, because that's going to give them relief, but you build it up to you, them having the trust, and you poking needles into their neck, and they're going to be walking out fine for sure. But absolutely.
And that's a fine, I must say. That's our founder of the school and an eminent surgeon of the Hess order. So when he asks, it's important.
Good. I like questions. A lot of times, there's more learned out of the question section than just the presentation. So absolutely, online is probably difficult to take questions. But what I can say is, if there's any questions afterwards, I will make myself available and I can answer any of them, for sure. But I think especially for places like Jamaica, and I come from Africa. I came from Canada to present, but I come from South Africa, so I understand the extra layer of complexity when it comes to the medical system, where you're working sometimes with limited resources, and even if it's not a limited resource, you're more conscious of where those resources are going, because you're just more conscious of the way you use things. We need to get to a point where we're not just serving the patient, the system needs assistance as well, and I think we can be much better, much more efficient. And there's obviously beautiful other things. Once you start understanding the myofascial system, there's 4 other modalities that you can add on top of it, but I think this is one of those that can start making a difference on a much bigger scale for sure.
Just like to ask, in terms of the release, may I do use dry needling as well?
Yes.
But I find that sometimes a little local anesthetic, small tension, so that you get immediate response and the patient is better. How do you find that in sort of your practice?
So there's a study, I don't know if I connected it to my presentation, where they actually did a double-blind study where they did with placebo and with lidocaine, with right-wing needling. And what they found is the needle effect actually that gives the biggest release. The lidocaine has no impact in general. So with myoactivation, what we do is we actually have saline in the syringe. So you're not injecting it, it's an in and out, but there's still micromolecules of saline that's going into the muscle. And if you understand the primovascular system, we're all bioenergetics anyway, so there's no electric component to it, and saline is a good conductor of electricity. So there is an extra component to something going into the muscle, but I know for a fact there's a study that said you do a similar process, and it's where you're needling that makes the biggest difference, not necessarily the lidocaine.
But what about dextrose? That would do full therapy.
Dextrose? I think it can be irritating just because our understanding of inflammation, that can just trigger the inflammation process. And once again, you're not injecting small amounts of things that go in. When I asked the gentleman that trained me, he was still very much in the structural mindset of the body, even though he understands the myofascial system, but he's limited in understanding of the bioenergetic and the electromagnetic part of the body. So when I asked him certain questions throughout the training, in his mind, we're just releasing hyaluronic acid that's now stuck, because those trigger points they found when they tested, it's actually hyaluronic acid that's stuck in trigger points. So we're releasing some of that. But he doesn't recognize that there's more going on to it, because if you release something, people have an immediate systemic effect. It's not just that trigger point area. So there's something connected to the primovascular system that goes beyond just the structural. It becomes electric, emotional, and the whole bioenergetic aspect to it.
Well, I can certainly, so I don't want to help it. I tend to get the patients where people are fed up, so I get them to do all these things. And one of the problems is 2 points you mentioned, a small release, and people go off to sleep. They'll sit there and just fall asleep with one stick and you think, why? But I use the example, I tend to use the example of the opioids and the endogenous opioids, but it's very true, but it helps to.
And I think that's a lot of times that autonomic nervous system release.
Right.
So because your brain apparently has no way of telling you when the muscle is contracted. A cramp it can feel, because it's immediately that lactic acid building up. But a contracted muscle fiber, the brain doesn't have a way to tell you. But it's still something that's been stuck for such a long time. That immediate release is that release from the brain to say, okay, I don't have to focus on that muscle anymore. So it becomes that immediate effect. The one thing we didn't talk about, and there's a study on myoactivation that focused just on scar release. Scar release is a massive part to this whole story. And obviously I couldn't put everything into the presentation, but scars are so underestimated. And that's where it can be very helpful, because most of the time, if you can prevent the compensatory patterns, there's very few surgery that's really needed in the first place. When there's surgery needed, afterwards, you need to go treat those scars. Otherwise, you're moving backwards. Maybe you treated the joint. There was some issue with the joint. But now the scar is messing up that whole myofascial chain, and you see them again in 5 years with other issues. system.
Just one quick question, simple. Is there a relationship with the whole art of acupressure, acupuncture, and myoactivation therapy? Because it would appear that that is the whole acupuncture, which of course is a needle, is still stimulation of these points. And of course, the acupressure, the physical activation of these points of tenderness that will produce, it would appear the same effect. Of course, it's possible a modification of the same therapy where you may then inject, whether it is a substance, whether inert or otherwise, to make that connection. Is there that kind of
There's the
relationship?
connection, I think the connection is once again the primal vascular system. So the myoactivation guys didn't necessarily connect the primal vascular system with what we're doing with Rochagné. So when you speak to acupuncturists, they don't tell you they're working with the physical body. It's the electric body that they're working with first on. So they're either interrupting a nervous system pathway that's the meridians. So what they found with the primal vascular system, it fits in perfectly with the meridian structure. So my understanding of acupuncture, and I'm not an acupuncturist, and I've had it done on me before, I think it's like a temporary break in the surface of that pathway of pain, first off, and sometimes I think they go through some of those parts, the primordial fluid, and there's a release, but they're not cutting through dense tissue. So once you take that needle away, it's the same with the needle with dry point. A lot of times the needle itself, it's a metal, so it doesn't matter what's inside, you're creating a conduction that bypasses that restriction. But if you don't cut through that tissue that's causing it, it's not necessarily going to have long-term results. There's absolute place for acupuncture, because I honestly think with a lot of our modalities, we need to bring in acupuncture instead of the medications and anesthesiology and all the things that comes with it. But it's still a temporary blockage of those pathways, where I think this is a reset of the way the body communicates as well.
What do you think of muscle relaxants, right, and anti-inflammatories? How do they actually activate?
So I'll ask.
Because that's what the majority of doctors do all over the world, including myself.
So when we look at low back pain, the one that we know is the biggest issue all over the world, the first thing they do when they go to an emergency department, in Canada they give you Toradol. They don't even have paracetamol there. So Toradol is the injection you get, and they send you on with a muscle relaxant and maybe an anti-inflammatory. The problem with the muscle relaxants, especially in the back, if those myofascial chains are not working, you've got other small little muscles that's now compensating, that's actually holding that spine in a position where they're not supposed to be doing that. They're overdoing their job. What you do to the body, you relax all of those muscles. And they've got no compensatory mechanism left. So they don't feel the pain because the muscles are relaxed, but that's where the injury starts, because that spine has no support anymore. So if they put them on muscle relaxants as a temporary relief measure, you actually should put them on a back brace, because they've got no brace left anymore. So now they think they feel better, they start moving around again, and they injure themselves, because they don't have that protection because of the muscle relaxants. The anti-inflammatories is also, out of the holistic point of view, it's a temporary thing, because it's not treating the underlying cause of the anti-inflammation or the inflammation, it's just breaking that pathway, the COX pathway. The problem with the anti-inflammatories is what it does to the gut. It still underestimates what we do to people's digestive systems with the anti-inflammatories. And once you mess around with the digestive system, you've got a whole set of problems that set in from the immune system, the nervous system, the mental health systems that stem from the gut issues. So we keep on exchanging short-term relief for long-term problems. Because the reason is, when going back to the emergency department, I will promise you this is the truth. There will be 2 physicians on shift, and there's a serious patient, diabetic ketoacidosis lying there. There's a back pain lying on the on the counter that you need to start taking new patients and there's a code blue coming in. I promise you, most of that emergency physicians would do all of the other serious stuff first before they take that back pain patient. And why? It's because they're frustrated. They don't know what to do for that patient. He's laughing because he knows it's the truth. He knows the truth. Because you know you're limited in what you can do for that person. And most of us still is in this job for the right reasons. We want to feel satisfied when we clock off after our shift. When you save somebody that came in a code blue, you go to bed very well because you've changed a life and you've changed a family's life. But if somebody comes in with back pain and you know you're not doing anything good for him, it bothers you even though you don't. You're not honest enough to tell you that. So you would rather hope that the other guy's finished first and he takes that back pain. So this is the thing that has changed my life as a clinician, probably the most of all of the training I've done. Because it brings back hope as a practitioner. So none of us want to be without answers when people are coming to us in a vulnerable position. But it's because we're not humble enough to say what we're doing is not working. And this is just one of those things that can start changing that. Any other
I
questions?
can only comment. I can only hope that a lot of people listening to this will understand and believe it, including quite a lot of our top orthopedic surgeons and the lawyers, because that's one of the problems we face
Absolutely.
here with medical reports. Oh, the MRI is normal, so therefore there's nothing wrong with you. And that is a serious problem we're having just now.
And they blame the patient. And once you have that label as a patient, we all know you've got that label once of people not believing that person is in pain, they're stuck with it for the rest of their life. That's the sad part about it. Thank you.
Fantastic. Yes. Well, that is the one for next week.
Dr. Russell.
That's what
Seriously. Side presentation. You know, Dr. Russell. Sure. Good afternoon. So, approximately 2 months ago, on February 20th to be exact, we were privileged to hear from and interact with Dr. Terrell, and Ms. Kumir, whose presentation topic examined the root of insomnia, anxiety, and PTSD. This lecture was well received. Today, we had a second lecture in the series for this year, presented by Dr. Kilian. I pause, however, at this point just to thank Dr. Gordon along with other colleagues for the vision and effort made in spearheading this lecture series. Thanks also to the staff members here, all staff who contributed in various ways to making this afternoon's presentation a success. I must also recognize all participants present here in the conference room as well as those who have joined online by Zoom. Dr. Kilian, I would like to express thanks to you for presenting this afternoon's lecture, Cutting Edge Assessment and Neuromodulation Technology that will optimize health and can be used alongside medicinal cannabis. We were able to experience your passion for areas such as holistic medicine and patient-centered care in addressing the root causes of dysfunction. The case studies presented some familiar situations, some of us in particular like knee pain, back pain, weight imbalance, and so on. The type of treatment and results were also discussed. We also got an insight into how to reboot our bodies, as well as how to move from protocol to purpose. I particularly like the quote that you ended with from Paracelsus. The art of healing comes from nature, not from the physician.
Therefore, the physician must start from nature with an open mind. Question and answer sessions allow for further elaborations on areas of interest as expressed by person. On behalf of the Caribbean School of Medical Sciences, Jamaica, I present you with this token. This token as an expression of our appreciation for sharing your expertise with us via this lecture. I know that the information presented has impacted all participants in a very positive way. Thank you so much.
Thank you all. We look forward to many.
Thank you.